I would now invite Dr. Anand Alladi, Professor and HOD of Head of Department of Pediatric Surgery at Vani Vilas Children's Hospital and Senior Consultant Pediatric Surgeon at Apollo Hospitals, Bangalore, for a brief enunciation of the techniques of pain relief in children following hypospadias surgery.
Thank you, Dr. Ramchandra. Good evening to all. Pain management in hypospadias, or any surgery for that matter, is a very important part of overall management of the surgical principles. I'll just try to briefly, just to stress the importance of pain management and what are the factors of pain we have to think about in pain management in hypospadias. All of us know what pain is. Basically, it summarizes that it's something which nobody likes to experience. It is, however, a very highly subjective phenomena. Each child has his or her own threshold for pain. The parent, and when you are talking about hypospadias, we also have to consider the parents, because we generally will be operating in age group of infancy to early childhood. So we also have to factor in the parents' reaction to pain and the reaction of the parents to perception and tolerance in the child. The four major components which are responsible for pain, which have to be dealt with at different stages in the management of hypospadias, are that caused by tissue injury. Any surgery will cause tissue injury and the body response to injury and inflammation. In addition to that, there are certain changes which can take place secondary to the secondary changes which take place in the postoperative period. Use of catheters, SPCs, different diversional techniques which can cause bladder spasm, and the most important fact being the functional or the psyche of the child and the parents. It is very important to start the pain management in the preoperative period. When we take the child into theatre, ideally we should have a child who is calm, comfortable, generally try to do it in the early hours of the day, so there's minimum fasting, which also adds on to a lot of distress to the child and indirectly to the parents. Parental accompaniment with the child to prevent stranger anxiety and which also adds on to the post-op morbidity. In this context, an appropriate and adequate pre-medication is ideal. Most of the anesthetists would follow some sort of oral sedatives, antipsychotic medications. Midazolam is the one which is used commonly. Oral midazolam can be given. If there is an IV access due to prior admission in the hospital for the child, IV midazolam can be used. Intranasal midazolam are also nowadays available, which produces effect within 5 to 15 minutes. So any of these can be used, and you generally get a very nice, calm, smiling child which can be taken into the theatre. Ketamine is also used as a pre-medicating agent, both in the oral forms and in parental forms. And in the morning, as the anesthetist had pointed out, clonidine is another agent which can be used in pre-medicating these children. Another important pain management concept is perioperative management of pain. This goes a long way in actually reducing or decreasing the requirement for postoperative pain relief. It is more of a preemptive measure which is taken to decrease the requirement for pain relief and also to have a smooth recovery. The common used techniques are all regional techniques, the commonest being the caudal blocks. Bupivacaine or Sensacaine, as it is commonly called, is the one which is used by giving caudal analgesia. This is generally given pre-operatively, and if the surgery prolongs more than 2 to 3 hours, a repeat dose can be given at the end of the surgery, again which was highlighted by the anesthetist today, where they left a catheter, left a Venflon and then gave a post-op shot before taking it out. There have been many medications which have been used as additives to bupivacaine, which are supposed to decrease the requirement of pain medication in the post-op period and increase the duration of pain relief in the post-op period. Some of these medications are ketamine, clonidine and morphine, which are all given along with the bupivacaine in the epidural space. Ring block or dorsal nerve blocks can also be used as adjuncts, but not many of us generally use this. Postoperative pain management starts off from the time the child is, the surgery is finished. Another small factor we need to consider is the dressing, that way we apply the dressing, because too tight a dressing, kinking of the catheter which causes retention or improper drainage causing bladder spasms or pericatheter leaks, too loose a dressing which can cause slipping of the dressing or edema which increases the pain, are all things which you have to keep in mind when you are applying the dressing. Before we start the post-op pain, we generally need to have some sort of rough assessment of pain. There are various scales which are available, which generally very few of us actually go into the details, but you should be able to have some sort of a scale which you are comfortable with, which can use to assess the degree of pain and use pain relief appropriately. Another important thing to remember is to have preemptive analgesic dosing and not use SOS dosings only when the pain occurs. Additional doses can be used in over and above what is routinely round-the-clock pain relief which is given. If more than one drug is required, as pain is a subjective phenomena, we generally start with the less toxic, few side effect pain medications and gradually go on adding on more and more depending on the requirement of the particular patient. If more than one drug is required, we generally prefer to add combinations or add drugs which have different modes of action. For example, using paracetamol with other NSAIDs with narcotics and combinations of those sorts. Post-operative pain relief basically takes care of the body response to tissue injury and pain caused by that. The commonest pain relief which is used is paracetamol, which is available in different forms. Oral medications which is given in the dose of 15 to 20 milligram per kg every 6 hours. Parectal suppositories are available, which can be given as a bolus dose of 40 milligram per hour as initiation and maintained at 15 to 20 milligram per kg per hour, per kg per dose, repeated 4 to 6 hourly. The problem with these parectal dosages are the absorption is very erratic, so you will not be able to get a very optimal response in all the children. Recently, paracetamol has been available in the intravenous form. Earlier, proparacetamol used to be available and was not being used much because of the other side effects. Paracetamol is being available now, and there are also people who have started using paracetamol as IV injections with the equal response as in oral paracetamol, but faster onset of action. Going on to the NSAIDs, ibuprofen is an agent which is used at a dose of 10 milligram per kg, 6 to 8 hourly, usually 8 hourly. Diclofenac again, which is available in oral and suppository forms at a dose of 1 milligram per kg every 8 hours. If these are not adequate in tackling pain, then narcotics can be added, keeping in mind monitoring which is required, appropriate dosage, side effects in the form of nausea and vomiting. Tramadol 1 to 2 milligram per kg, buprenorphine or morphine are the narcotics which can be generally used, but all these require a proper post-operative nursing care monitoring and titration of doses for each patient. Bladder spasms are also something we deal with. Some of us use routinely anticholinergics in the form of oxybutynin, 0.2 milligram per kg every 8 to 6 hourly. Sometimes in real severe forms, to get immediate relief, as Dr. Sudipta had just mentioned, intra-bladder instillation of either local anesthetic agents or bladder sedatives like midazolam and diazepam or xylocaine and sensocaine can be used. I think I'll just stop there. This is just a brief outline of what is important factor which is to be considered in post-operative management of patients with hypospadias. There are lots of drugs which are available, lots of combination permutations. Basically, you need to use something which the anesthetist and your particular unit is familiar with and comfortable with. Thank you.
Thank you, Anand, for a very practical, detailed discussion on the pain relief. We have any questions from the audience?
A question for the pediatrician. Tell me that oxybutynin, you have to be next. Everybody who had been advocating since morning for the children's bladder spasm. What is the role of the newer drugs like tolterodine, solifenacin, and eriferacin in pediatric age group? How safe they are?
Oxybutynin generally we use when you use short, because most of the time you'll be using this for few days, for 5 to 7 days as far as the catheter is left in C2, and shorter duration, more frequent dosing. Tolterodine and other drugs are used in pediatric practice when you are using it for neurogenic bladders and other purposes, and long acting, but then you don't get a constant prolonged equitable distribution. Sometimes you use it once a day and sometimes you need to use it twice a day. They are available only in the capsule forms, and only 2 and 4 milligrams capsules are available. So adjusting the doses become very difficult, and when you are operating children as small as 6 to 12 months of age, if you look at actually the kg per kg dosage of tolterodine, the requirement is very low. So it comes down to as low as 0.5 to 1 milligram. So to get a capsule and break it down to 0.5 and 1 milligram is difficult. So generally, I don't know if anybody uses it, but most of us use oxybutynin, which we are all comfortable with. Thank you.
Thank you, Anand. Thanks a lot.